Abscesses around the anal canal arise from infection of the anal crypt of Morgagni, figure 2, and can be either superficial perianal abscesses, 80%, or deeper ischiorectal abscesses, 20%, figure 3. A perianal abscess is found adjacent to the anal canal, either on the right or left side, anterior or posterior. The patient usually complains of pain that may be, but not always, associated with a fever. The diagnosis is made by inspection of the perianal area, which will reveal a red, angry, and often fluctuant abscess. A digital examination should not be done due to the painful nature of the problem. Figure 3 shows the location of perianal and pararectal abscesses. Abscesses are classified according to the spaces they invade. Most superficial perianal abscesses can be drained safely in the office and do not require operative drainage. The most difficult to treat are those that track proximally or circumferentially within the intersphincteric plane or within the ischiorectal fossa or postanal space. Examination under anesthesia may be required to determine the location and extent of the abscess. An ischiorectal abscess, however, is large, involves either the right or the left ischiorectal space or the deep postanal space, and requires operative drainage for office drainage. The patient should be placed in the standard kneeling position on a Ritter table. For operative drainage, a prone, jackknife position is best. If done in the operating room, a general or spinal anesthetic is desirable for a perianal abscess. The skin over the abscess is numbed with ethylene chloride. Injection of the site with xylocaine is excessively painful and unnecessary. Once the area is sufficiently numbed, a stab incision is made over the abscess to drain pus. This should be sufficiently large to allow adequate drainage. There is no need to excessively probe this abscess. The incision should be made as close to the anal canal as possible so that if a fistula in ano does develop, the fistula tract will be as short as possible. Ischiorectal abscesses are drained immediately. Careful palpation often shows evidence of fluctuation not seen in the perianal tissue. Operation is not delayed until fluctuation is obvious, because a perirectal abscess may rupture through the levator muscle into the retroperitoneal tissue. No special preoperative preparation is required. Antibiotic therapy is given. General anesthesia with endotracheal intubation may be used. However, regional anesthesia, either spinal or epidural, is satisfactory. The prone or jackknife position is preferred for drainage. The common locations of ischiorectal abscesses are shown in Figure 3. Abscesses may be located extraperitoneally above the levator ani muscle. Careful rectal and sigmoidoscopic examination should be performed to detect associated pathologic processes after the patient has been ANES. The TIS. An incision is made at the maximum point of tenderness, Figure 3, and placed either parallel or radial to the anus. If the abscess lies above the levator, the incision is deepened radially to avoid nerves and blood vessels. After incision and drainage, the cavity is explored with the index finger to ensure complete drainage and to ascertain that no foreign body is in the ischiorectal space. A specimen of the draining material is obtained for bacteriologic studies. Usually, there is no communication with the rectum. If the abscess is small and a clear communication with the rectum is identified, the tract may be excised. The outer opening must be sufficiently large. For the common error is to drain a large cavity through a comparatively small incision, resulting in the development of a chronic abscess. The cavity is lightly packed with a gauze tape. Moist compresses and sitz baths reduce inflammation and promote rapid healing. Postoperative dressings to ensure healing from the bottom are as important as the operation. An ischiorectal abscess is prone to result in an anal fistula. However, in about half of the cases, there will be primary healing. With proper postoperative care, the majority of anal fistulae result from infection arising in a crypt, extending into the perianal musculature, and then rupturing either into the ischiorectal fossa or superficial pararectal tissues. Operative obliteration of the fistula is always indicated if the patient's general condition is good. Treatment of anal fistulae presupposes a knowledge of anal anatomy, particularly of the sphincter muscles and their relation to the anal crypts. A study of Figure 1 will clarify several important points. As shown in Figure 1, the external sphincter muscle can be divided into three portions: the subcutaneous, superficial, and deep portions. The subcutaneous portion lies just beneath the skin and below the lower edge of the internal sphincter, Figure 1. The superficial and deep portions surround the deeper part of the internal sphincter and continue upward to join with the levator muscle, Figure 1. The levator ani surrounds the anal canal laterally and posteriorly, but it is absent anteriorly, Figure 1. The longitudinal muscle of the anus is the continuation downward of the longitudinal muscle of the large bowel, Figure 1. The internal sphincter muscle is a bulbous thickening of the circular muscle coat of the large bowel. The superficial external sphincter is palpated as a band surrounding the anal canal just beneath the skin, Figure 1. Just above it is felt a slight depression, the intersphincteric line, and the slight swelling above this point is the lower edge of the internal sphincter, Figure 1. If the finger is introduced into the canal and hooked around the entire anorectal ring anteriorly, it contacts the deep portion of the external sphincter, the levator being absent in this location, Figure 1. As the finger is rotated posteriorly, in contact with the midline of the canal laterally, a distinct thickening is felt as the levator ani, Figure 1, joins the canal, and posteriorly the anal canal feels thicker than it does anteriorly. Incontinence will not occur if any portion of the external sphincter or levator muscle remains intact. Most fistulae arise in the anal glands at the base of the crypts of Morgagni. Therefore, the abscess usually lies within the substance of the internal sphinx tear, Figure 2. It extravasates through the muscle, tending to follow the tissue planes created by the fibromuscular septa of the longitudinal muscle. Fistulae rarely arise from perforations of the anal canal associated with foreign bodies or abscesses, as in tuberculosis or ulcerative colitis. The internal opening may be above the pectinate line and may traverse the entire sphincter or portions of the levator, Figure 3f. It may be necessary to operate in stages or to use the Seton technique, Figure 14, to avoid incontinence. Fistulae in Ano usually follow Salmon-Goodsell's rule. If located anteriorly, there is a radial tract, Figure 5a. If posterior, there is a curved tract, Figure 5b, c, d. Simple anal fistulae, Figure 5a, follow a direct route in the anus. Complicated fistulae, Figure 5b and c, follow a more devious route, often horseshoe in shape and with numerous openings. Most complicated fistulous tracts open into the posterior half of the anus. Should the fistula have multiple sinuses, the main exit will usually be posterior, even though one opening is anterior to the line. Figure 5, XX, a single fistulous opening anterior to XX usually extends directly into the anterior half of the anus. Figure 5a. Goodsell's rule: local abscesses are drained if there is pock-eating or cellulitis. If there is no severe local inflammation, a cleaning enema is given the night before operation. No cathartic is necessary. Inhalation anesthesia is the procedure of choice when dealing with a complicated fistula. Spinal anesthesia is satisfactory for simple fistulae and may be used for more complicated fistulae. However, it provides such complete relaxation of the musculature that palpation and recognition of the divisions of the external sphincter and levator are sometimes impossible. The anal canal may be dilated just enough to permit introduction of a self-retaining retractor. The pectinate line is directly visualized, and anal crypts that may reveal the internal opening are inspected. Gentle probing of suspected crypts may reveal an unusually deep crypt, which, from the position of its external opening, can be recognized as the source of the fistula. Figure 6. If a normal pectinate line is found, with shallow crypts or no crypts at all, it is likely to be a local perianal abscess with no direct communication with the anal canal. Some surgeons prefer to inject hydrogen peroxide into the external opening to trace the fistulous tract to its inner opening. After the internal opening of a simple fistula has been identified, a probe is introduced into the external opening and gently passed down the tract into the internal opening. Figure 7. Care is taken to avoid creation of a false passage. The incision is made on the probe, and the tract is laid open. Figure 8. It is not necessary to excise the fistula. The tract should lie open as shown in Figure 9. In a simple superficial fistula, the entire tract may be stabilized with a probe as it is excised with scissors with electrocautery for complex fistulae such as a horseshoe fistula, with an external opening anterior to the midinal line and an internal opening in the posterior midline. Extensive incisions are avoided. The main posterior tract is identified with a probe. Figure 10. A short posterior portion of the tract is unroofed and the involved crypt excised. Figure 11. The anterior tracts are curated and drained via soft rubber. Penrose drains through secondary incisions along the tracts. Figure 12. The posterior tract is marsupialized. Figure 13. If a large transsphincteric fistula involving a significant amount of external sphincter muscle is present, a seton should be placed. The probe is first passed from the external opening to the internal opening, and a zero silk suture is tied around the groove in the probe. Figure 14. The probe with the suture is then pulled back through the fistula tract, and the zero silk suture is tied tightly around the muscle. All fat and skin are removed, leaving the seton compressing sphincter muscle only. Silk is an irritant, and with time the silk will cut through the sphincter muscle. However, the fistulotomy will be performed incrementally, giving time for the sphincter to heal. The fistula is slowly drawn out by the seton. This protects against incontinence by preventing the sphincter muscle from separating, as would happen during a fistulotomy. A non-cutting seton using a vessel loop is indicated in chronic perianal disease. The patient may be out of bed as soon as the anesthesia has worn off. The patient is allowed a light diet, and there is no attempt to restrain bowel movements. Stool softeners are prescribed. Sitz baths may be started on the second day following operation. Patients may be discharged the day of surgery and are seen within 1 week. An alternative therapy for a complex fistula is an endorectal advancement flap. Figure 15. A flap with mucosa and submucosa is created to include the internal opening. Figure 16. The dissection is carried far enough proximal until the flap can be advanced distally without tension. The internal opening is excised, and then the flap is matured to the intersphincteric groove. Figure 17. The external sphincter may be plicated to close the fistula opening, and then the flap is sutured to the intersphincteric groove with interrupted absorbable sutures. Figure 17. This effectively treats a complex fistula in Ano with minimal risk of injury to The sphincter muscles fissure in Ano is a common painful condition that can be found in children and adults alike. These wounds usually heal spontaneously in children but may require operative correction in adults. It is usually caused by constipation or a large traumatic bowel movement, and it is almost always located posterior. The fissure, which runs between the dentate line and anal verge, if deep enough, exposes the internal sphincter muscle. This causes considerable spasm and pain. Chronic fissures may be associated with a hypertrophied anal papilla and a skin tag. Over a period of time, the internal sphincter muscle hypertrophies, becoming more effective in keeping the wound open and preventing spontaneous closure of the fissure. Topical salves and fiber are usually effective early on. Once the wound becomes chronic, surgical repair is usually necessary. No preoperative preparation is necessary. The cleaning enema, which is such an excruciating procedure to the patient, is omitted. Spinal, epidural, or local anesthesia is satisfactory. The field is prepared with local antiseptic solution. No attempt is made to dilate the canal and irrigate the rectum. The patient is placed in the position as shown and prepped and draped in the usual fashion. The prone jackknife position may be used. A Hill-Ferguson retractor is placed in the anal canal, and the anal canal is inspected. The fissure is usually posterior and may be associated with a right posterior hemorrhoid, figure 18. The fissure and the hemorrhoid, if necessary, figure 19, are excised and the anal mucosa and anoderm closed with a running 2:0 chromic suture, figure 20. A lateral internal sphincterotomy is performed to reduce sphincter spasm. A separate incision is then made in the left lateral position, again excising the hemorrhoid in that location if necessary, to expose the hypertrophied internal sphincter muscle. A partial lateral internal sphincterotomy is done in this position. This wound is closed with a running 2:0 chromic stitch. The procedure may be done as a closed technique. With the finger in the anal canal, an 11 blade is inserted into the intersphincteric plane staying below the dentate line, figure 21. The blade is then moved medially, divoting the inferior 1/3 to 1/2 of the internal sphincter, figure 22. An open technique may be done. A skin incision is made, figure 23. A hypertrophied band of internal sphincter is freed and elevated, figure 24. The internal sphincter is then partially divided, figure 25. The wound is left open. The sphincterotomy is done in the lateral position to avoid creating a keyhole deformity, a complication of the procedure that can be challenging to correct. This procedure removes the chronic fissure in Ano and releases the tension on the anal canal sufficiently enough to allow the fissure to heal. Patients are allowed out of bed and encouraged to move their bowels as soon as possible after operation. Daily sits, baths and daily rectal examinations are indicated to ensure that granulations do not build up and protrude into the anal canal. The patient should be kept under weekly observation after discharge until healing is complete.